What's on the horizon, if I can put you on the spot?
Of course, it's a combination. So I think chemotherapy is not completely out. I think it's reasonable to combine things because, I mean, it takes some time to acquire an immune response. I mean, we're not completely clear about this because we don't have, continuous monitoring of tumor response in these patients. But there seems to be a certain delay until you have some response. So the question would be, if you kick in some chemotherapy, will it rescue patients, give them more time to get a immune response? Or, the release of antigens is something that is being discussed. I mean, these are all hypotheses. So, but if you ask me, is there a role for chemotherapy plus immunotherapy? I would say yes, there is, and it's worthwhile to explore.
And certainly there are studies exploring it. So we have data from pembrolizumab single agent showing efficacy and good tolerability. We have data with nivolumab versus chemotherapy showing an improvement in overall survival. We have some biomarker data suggesting that PD-L1 may be an enrichment strategy for patients for PD-1 blockade, but we don't select our patients based on PD-L1 expression. And but of course the field isn't stopping there. Kevin, there's a lot more on the horizon with respect to immunotherapy. Tell us what's going on. Tell us what you're excited about and where the field is going to go.
I think it's very difficult to predict exactly where the field's going to go, and that's what makes it so exciting. What I do know is, of course, that there is significant clinical trial activity around other PD targeted agents, in particular around the PD-L1 axis. So, for instance, drugs such as durvalumab, and the data set from the cohort of head and neck cancer patients, the 62 patients treated in the 1108 study with single-agent durvalumab, show that that is also an active agent with a response rate of around about 11%. And we know that another PD-L1 targeted drug, avelumab, has activity again in an enlarged cohort in patients with head and neck cancers. We know that for at least two of these agents, nivolumab and durvalumab, there is a strategy to combine them with CTLA-4 blockade, respectively with tremelimumab for durvalumab and with ipilimumab for nivolumab.
Kevin, on that point, I'll interrupt you for a second, but please, if you don't mind, what's the rationale behind that? Just explain that for us.
Yeah, so in terms of the aspects of trying to drive an anti-tumor immune response, we've paid a great deal of attention to the checkpoint around the PD-1, PD-L1 axis. But of course, that is at the level of the effector phase of the immune response. Whereas if we go back a step and we think really about the priming phase and the activation of those T cells and licensing of those T cells for anti-tumor activity, the role of CTLA-4 blockade really gives us another level of activity, a second break that we can disengage and that we can allow the immune system to become further activated. So this dual blockade has been demonstrated to be significantly active in other disease types, and melanoma being the case in point, whereby the double action of nivolumab and ipilimumab delivered response rates in the mid-50%, with significant toxicity, it has to be said, but nonetheless significant response rates, and we're waiting for those final analyses to show the overall survival benefit. So I think there is again an interest in doing those sorts of things in head and neck cancer.
Yeah, so even though they're both called checkpoint inhibitors, I wanted to clarify for the audience that they clearly hit different checkpoints in different parts of the immunotherapy cycle.
Yes, indeed, and there's and potentially also in different compartments of the immune cycle, of the immune response. We know also, and it's more complicated than maybe we've just described, because we know that one of the roles of ipilimumab is it can deplete regulatory T cells, both within peripheral lymphoid tissues, but also actually within the tumor cell, the tumor mass itself. And so there may be other multiplicities of activity. So I think the interaction of PD-1, PD-L1 inhibitors with CTLA-4 inhibitors is a really exciting area. And of course, we have first-line trials now, randomized phase 3 trials already underway in the case of the AstraZeneca Kestrel study, and planned and indeed just activated, I think, here in the US with the Checkmate 651 study. In addition, of course, there is a whole wave of new drugs coming down the various pharmaceutical pipelines, and I think that's a cause for huge optimism and again for huge enthusiasm, because we have drugs that will engage with multiple aspects of the immune response, including the stimulatory side of the immune synapse. So drugs such as CD137 targeted drugs, 41BB, OX40, CD40, I think those represent very exciting drugs. And there's also the opportunity, in fact, to engage other elements of the innate immune response. So drugs that activate NK cells, drugs targeting KIR, for instance, drugs that act as true innate activators, such as the toll-like receptor agonists, STING receptor agonists, and an area of particular interest to me, which again I have to declare a conflict about, which is the use of oncolytic virus therapies. And indeed, the drug telimagene laherparepvec, that is TVEC, or Imlygic, which has been approved in the treatment of melanoma, is now being brought to bear in head and neck cancer with a phase 1b study, which we hope will roll into a phase 3 study of TVEC in combination with pembrolizumab, and the idea being there that a tumor-specific virus infection acting as an immune stimulant and an inflammatory stimulant will actually enable pembrolizumab to have a greater activity systemically. And I think that's hugely exciting.
And certainly if the melanoma data are any indication, there's reason to be excited with telimagene laherparepvec in combination with a checkpoint inhibitor. And Kevin, I share your excitement. Tanguy, tell us a little bit more about some other combinations and how you see them coming into play in head and neck cancer.
So by and large, I would kind of as an overarching theme say that we're just starting to scratch the surface of immunotherapy. It's a new modality. It is non-cross resistant with anything that we've done before, chemotherapy, radiation. It is a new modality. And if you think about it, 70% of tumors have some level of head and neck tumors, have some level of PD-L1 expression, some level of inflammation, but we only see responses in 15 to 18% of patients. So the pool of patients who might benefit from combinations is huge. I believe that the next 5-10 years will see leaps and bounds of progress. So I'm an optimist, and I think many are optimistic because it's a new modality, it's a new mechanism, and there are clear indications that we can do better. And as was pointed out, we see in other diseases that some of those combinations look very promising. So I think, in the first-line setting right now, I think we have two strategies that clearly look promising, one being the combination with chemotherapy. And, we again see data in lung cancer that looks striking, combining a PD-1 inhibitor with chemotherapy. But at the same time, there's also the other strategy, looking at the combination with a second checkpoint inhibitor. Again, striking activity in melanoma, some activity in lung cancer. So I think those two strategies both look promising. And I wonder if they may actually hit different things because, PD-L1 positivity versus PD-L1 negativity might actually make a difference. So I think progress will be profound and probably will lead to first-line approval of one of those combinations or probably both. But I also think there's a ton of other targets, and I think Kevin actually really comprehensively, maybe not comprehensively, but really mentioned many of the promising targets. So I'm a big fan of making tumors inflamed. In fact, I believe, if you look at the data, non-inflamed tumors are, in my mind, the most challenging tumors to go after. That's not just PD-L1 negative, but truly getting the T cells into the tumor. And I think TVEC is one strategy. It has a very different profile from actually the immune checkpoints. STING may be another one, and there is great preclinical data. STING actually just entered clinical trials. We are treating our first patient with head and neck cancer right now. So I think there's a lot to come. I think the NK cell strategies will likely see data at SITC of the first strategy there. And again, I'm very curious to see this. And ultimately, there are other targets that may actually help work on T regulatory cells, another immune suppressive mechanism, so CTLA-4 targeting may do this. But there's also this target called IDO. There's a drug, or actually multiple drugs, that are IDO inhibitors, and they may actually provide a less toxic alternative. And again, we have to wait for the clinical data. But I think there's a large number of combinations, in fact, too many to list. There's so much activity, and ultimately, this is really good for patients. If you go back 10 years or even 5 years, there was very little clinical trial activity study for head and neck cancer, but now we're seeing a wealth of trials, so much interest. And I think it's really important for patients to seek out trials, to go to centers that offer trials, because there's a high chance, in my mind, and maybe I'm a little bit biased, that some of these combinations will hit and actually provide additional benefits. So I'm an optimist. I think the future is bright, and immunotherapy will be important for many, many patients.
Yeah, Tanguy, I share your biases, but quite honestly, and not in a facetious way, I really do believe that the best therapy that we can offer to patients now is in the context of a clinical trial, because there is so much going on and so many, especially new immunotherapies. And again, to illustrate your point about the IDO inhibitors, if the data that we're seeing in melanoma and non-small cell lung cancer translates into head and neck cancer, we've got a combination that has great potential, and obviously we'd like to see the data in head and neck cancer.